All right. Good afternoon, everyone. Joya Goodrum here with the McMinnville Chamber. We are going to be hearing today a presentation on Oregon Saves and opportunities for businesses in utilizing that program through the state. We have Jason here who is going to tell us all about it. So Jason, I'm going to turn it over to you and let you do your thing. And if people have questions, post them in the chat, please. And please put yourselves on mute so we can hear everything that Jason has to say. Thanks.
All right. Thank you. Well, I'll start with introducing myself. My name is Jason Henness. I work with the Yamhill County Health and Human Services. So we are county employees serving the entire county. And my role is behavioral health director. So a lot of what Health and Human Services is composed of is behavioral health services, in addition to like the public health, which became much more publicly aware during the recent pandemic. And then we have developmental disabilities and veteran services and things like that, which are smaller departments. Behavioral health, yeah.
I'm sorry, it's behavioral health today. Oregon Saves is another time.
One of the things I was going to get to was a question about maybe calling things something different.
Looking at the wrong day on my calendar. Oh my God, I'm so sorry, everyone. Jason is with the county. I knew that. Oh my gosh, I'm so sorry. Please. I was
going to get to the point asking what Oregon Saves was and thought maybe that was a different terminology that was maybe being applied to some of the things I was going to talk about. Because I could see how it would fit in just naming it. I
messed up. I'm so sorry.
Okay. So behavioral health, when we say behavioral health, what we're really doing is it's kind of a term that encompasses mental health services and addictions treatment or substance use disorder treatment services. And I believe the primary interest around that is probably what we have in the way of sort of community outreach and support services, especially around crisis. And I thought it might be helpful to get to that, but starting with more of like a maybe higher level of like all of the things we do and what's available and the services we're providing to people. And then what that looks like, that's more of like a general community resource and kind of how that's growing and changing in a positive way right now. So at least that's kind of my rough agenda. I don't have a lot of slides. I do have, I think one slide I'll probably share, sort of an infographic. And there's always time for questions if people want to hold those to the end, or if something is just like, I don't know what you're talking about right now, confusion, just shoot a hand up, put it in the chat or something like that. And I can always take those in the middle too as we're going. So I've been with Health and Human Services for 8 years, moved to McMinnville. And when I got hired here at the county, was an out-of-state transplant, came up here, got the job, loved the community when I came and interviewed, just drove down 3rd Street and was like, this is a cool place. So I was excited to interview on my drive here because I was coming from the Portland area. And fell in love with it, got hired, bought a house here, started the family here, and have kind of over the last 8 years held a number of roles up until now. I'm the behavioral health director. We have, you guys probably are aware of our footprint in the downtown area. So lots of offices kind of spread around here north of 3rd Street, serving adult services. Adult behavioral health is our largest office, largest program on between Evans and Davis. And then we have our family and youth program, which serves essentially children, minors. And then we have some specialty programs like people call it the Abacus House still some, but it's a community service where treatment teams are going out and working with clients that we have, but more in the community and in their homes. The other clinic is like our outpatient clinic where people come to us and they come in for their appointment times and things like that. So different levels of service that we provide, everything from, episodic, trauma, grief, depression, anxiety, to severe persistent mental illness that affects someone over the lifespan. And they maybe have more intensive services, multiple people that are working with them ongoing. That includes things like medication management. It includes things like counseling in individuals and groups. It includes things like sometimes people that will go out and work with people in the community, might be taking them to appointments, resources, and connecting them with things like that. We are a larger organization than a lot of people realize, I think. Our number of employees just in behavioral health is, gosh, over 250. And not all of them are sort of in McMinnville, but that's really our hub and where most of us are located. We have a smaller office in Newburgh. We have some people that are stationed out in the community at like school-based health centers and things like that, small numbers in those ways. And then addiction services or substance use disorder treatment is modeled very similarly. It happens in the same clinic settings. We say that we have an integrated program, so someone can come and get both services from us. They might have a counselor who does both. They might have different counselors, one for mental health, one for addictions. They can be sort of enrolled into programming, sort of customized to that person's needs. What else do I want to say? We work really closely with some of the partner organizations. So we have referrals in close partnership with the community justice. So that, you know, it's parole, probation, the jail. We have close relationships with law enforcement, the sheriff's office, MacPD, child welfare, Oregon DHS, the school districts, all of them except for one in Yamhill County. So we've got contract relationships with some of them, agreements with some of them. And some of them are like, we have staff co-located in some places and things like that. So lots of great coordination. One of the things I really like about Yamhill County and McMinnville in particular is just the, and I came from LA County, so that sort of gives some context to this. People actually know who the people are in other programs and departments, like by name. And that was sort of, for me, it was my welcome to the community was when I got hired and they said, hey, you need to go get your like fingerprinting done, like over at the courthouse. And they said the person's name. And I was like, okay. Like they knew the security guard at the courthouse by first name. And so that, and then I've come to realize and sort of that's the way the community is and thrives. And it gives us a lot more ability to work together in partnership and to get better coordination around the people that we're trying to help, the community members, and as we refer to a lot of the people, our clients. So I really like that. We have crisis services available separate from in the community, but like we have crisis services available to anyone in the community. We have a responsibility for that around, so the state, Oregon Health Authority, mandates things for community mental health programs. We have a responsibility to be like what we say, like the safety net service for the community, which means people who are in crisis, mental health crisis, can come to us. We have business hours where they can walk in, phone numbers they can call, 24 hour, 7 day a week, hotline number for crisis. And then we sort of are open to serving anyone and sometimes connecting them if they have other private insurance and things like that. But really, it's open access, open door for anyone in the community, especially when in crisis or needing things like, we would say like a placement or a higher level of care, like to go to a psych hospital. So that's our responsibility to meet with those people, make that evaluation and recommendation, and then make that referral and see that they get placed into those programs. And then when they come back, sort of give them an opportunity to meet and enroll in our services. So those are some responsibilities of just a general community mental health program that every county has someone that's responsible for those things. And for Yamhill, it's HHS. Crisis services for youth and adults, we have two different teams. So the youth program has their own youth services team for crisis, calling their office during the day. Someone can talk to their crisis workers that are sort of available on standby. The adult office at Adult Behavioral Health has their walk-in crisis team during the day. People can walk in and meet with someone immediately. So we just, have people that are sort of scheduled to be available for walk-ins. And usually that is for either they want to enroll in services, and so they're interested right now to come in and do what they need to do to get started, or there's a sort of crisis and a risk evaluation that needs to be made, and sometimes coming up with a plan for them to stay safe. So it's like that immediate or urgent need, and we encourage them to come in right away. Is there a question for me? I can see it on your face. Yeah. Go ahead. Yeah.
Okay, I have several questions. So, so I've heard that there's not a lot of beds in the psychiatric, in the Oregon State Hospital. And so are you seeing that people can't get the care that they need because there are no beds?
Yeah, that's a really good question. We can go down that for a bit. Oregon State Hospital does not have enough bed capacity for the needs of the state the way that it's been operating. So Oregon State Hospital is like the highest level of care in the state, right? It is inpatient services for populations that are there under aid and assist. So they have criminal charges, unable to aid in their own defense. They get sent to the state hospital to be restored so they can come back and aid in their defense. So they serve primarily aid and assist populations, and that's basically keeping them busy at this point, full time. And then they take civil commitment, which is someone who is civilly committed for inpatient services involuntarily against their will by a court process.
Right.
Those are harder to get in because of the number of aid and assist ones right now. So that's primarily what the state hospital does. Then there are other inpatient hospitals that are brief psychiatric hospitalization. It's like Salem Hospital, Providence runs some, Willamette Valley, or not Willamette, Willamette Falls. Is it Providence, Willamette Falls, Providence, St. Vincent, Cedar Hills Hospital across the state. So the inpatient psychiatric beds are a statewide resource. So Yamhill County has a person we want to refer to go to a psych hospital. We send referrals to every hospital in the state, and then you just kind of go wherever you get accepted. Those are usually brief stays to stabilize on medication. So it's not really long-term treatment in any sort of regard in those hospital stays. It's more like, trying to think of like, what would the physical health model be? It's more like you go into the emergency department or ICU. ICU is a good one. It's more like ICU. And you go into ICU because you have intensive needs right now, and you get care there until you're okay to discharge to a lower level, like maybe their recovery ward or home health, like, you know, supported nursing at home or rehab facility or something like that. So that's kind of what psychiatric inpatient is for the state. And so we will refer to them, and it is easy to get someone referred into psychiatric inpatient. It's usually a day or two wait, but they might be there for a week. And then they've got a new medication that they've started, and we think this is helping, and your discharge planned back to the community to engage in your outpatient services. So that's how the system functions today. So there is a big gap between people who go in for the acute psychiatric hospitalization and stay and then come back, and people who get sent to the state hospital and can sometimes be gone for months to years. And because of the long-term stay at Oregon State Hospital, the turnover is is small, and that's why it doesn't have a lot of capacity for new people.
Wow.
So it is a problem, and they're trying to solve for that problem currently by funding the community mental health programs more to try to just do more locally for people in outpatient.
Sorry,
yeah.
go ahead.
No,
I was
you
just
had a
going to
question on
ask,
that.
so how does that work? You know, I mean, you hear about people, and I'm just going with hearsay, okay, because I don't know this for a fact. So you hear about people who go into, you know, a treatment facility or, you know, the psych ward, whatever, for their week or however long they're stabilized. They get out and they get sent out with medication, and then the next thing you know, they're off their meds, you know, and the recidivism happens, right? So what
100%.
I mean, it's so sad.
Yeah. So what it's sad. It's sad for sort of the family members and the loved ones that see it happening. It's sad for the law enforcement. It's like this person again. It's sad for the business and the community. It's sad for our teams and the people that work with them too, because we do have a lot of things that could be helpful available, and it's all voluntary up until the point that you get civilly committed by a judge. So there is, there's again that sort of gap between the authority that we're given by like the state law to intervene and involuntarily commit someone. So we sort of evaluate them, we take it to court, the judge says yes, they have to go to the hospital. And then when the hospital says they're done, that commitment process is sort of completed and they're back to their own, they have to voluntarily do the follow-up after that. And that's where you see the recidivism of, well, if they don't choose to, and then they're likely to repeat that sort of behavior. There is thought and advocacy that's happening, for, through the legislature to give a little more authority to being able to mandate services without it having to be the most extreme risk scenarios. And that is sort of, weighed against like someone's civil liberties, and how do people feel about that too, because they are essentially held against their will. It's not too different from suspending someone's civil liberties for a crime when they're incarcerated and things like that. So there's people on both sides that think like, no, it should be voluntary. And there's people who say, yeah, but then people don't get the help they need. And we could do so much more for them if we could make them do it. I think there are some things in between, like people on probation can be required by the court to follow treatment recommendations, right? So they're supposed to, or they face the legal consequences of parole violations and things like that, sanctions. So there are other ways that the system in the legal side has of compelling people to do it. But again, it's not a forced, because they could just face the consequence, right? So there are limits to what we can do in that regard, which is why we focus a few things. We focus on accessibility. So one of I think the misnomers in, and maybe it's worse in other communities than here, is it's so hard to get into services, long wait lists, it's not available. That is more the reality in the sort of private practice, private insurance world than it is in the community mental health programs, Oregon Health Plan, Medicaid coverage. We have requirements and mandates that we don't have a waiting list. Like we just take people in. If they come, we take them in. And we have sort of required access timelines so that we can't like book things too far out. So our front door is pretty wide open. People get in to services. Yeah. When there are things like the sort of people were talking about the behavioral health workforce shortage or medical provider workforce shortages and things like that, those were real, and it was worse during the pandemic, of course. So what was happening was people were still getting into services, getting in the front door, and then we sort of are triaging, like, or we've only got so much provider time to distribute between now more clients, so you get less time, so you're seen less frequently, but you still get in. So those were the ways that we managed for things like having some staff shortages or an increase in demand, is everybody gets in, but then people just get their appointments booked further out in between. That is actually for us, we're really coming out of that now. We've seen an increase in our hiring to be back to what is sort of our pre-pandemic levels. And so we are in a pretty good place for that, and don't want people to think that there's not help available. That's one of my big sort of pushes whenever I'm doing a sort of presentation, is like, there is help available. People should try and seek help. If people find that the barriers to, like, I don't know what it's going to cost, I don't have insurance and those kinds of things, we say, come to us still, because number one, Oregon Health Plan covers everything, no cost. If people aren't eligible for Oregon Health Plan, they have no insurance. We are supposed to see them as the community mental health program, so indigent, no insurance. If people are privately insured but like underinsured and there's nowhere for them to go, because private practice people can have wait lists as long as they want and stop taking referrals, we take them in and we say, we'll work with you, and if you can get connected somewhere else, like, we'll see you until then. So we are funded too. We have different grant funds, state dollars that we receive in addition to like the insurance reimbursements and things, so that nobody should be turned away from us due to insurance or ability to pay. And then we do sliding scales for people that are like, sometimes like you pay $5 for every visit. Then that's just
So
just
do you
because
have
that's
to have
what seemed like
Oregon
they
Health-
could. Mhm.
I'm sorry, do you have to have Oregon Health Plan to, or be eligible for it? Someone who has health insurance, can they come and see you?
Yes.
Oh.
Yes. So if someone who has any health insurance, they can come, and we might, encourage them to, have you tried your private insurance?
Right.
Yeah, but they told me they weren't gonna be open for like 6 months. Okay, then come here, stay on their waiting list, come here, and then if you want to switch, then you can switch, when they're available. But no, nobody is turned away due to insurance. And we try to, especially most of the people that we're working with are people that otherwise would probably be likely to be coming in crisis or going to the hospital. And so it's also recognizing that we can intervene earlier if they will
Right.
come to us in those ways too. So
I presume you work with the hospital when they get someone in who is in crisis, and
Mhm.
you assist
Yeah.
the hospital.
So we are the there's two parts to this answer. So both Willamette Valley Medical Center and Providence and Newburgh have an emergency department.
Right.
And we are the mental health screening for both hospitals, but also in Providence, George Fox psychology students who are doing their like internship. We contract with them to cover certain hours out at Providence because they can do that work too, and it gives them a good experience. But so if somebody is in a mental health emergency crisis, so say the family takes them there, they take themselves there, law enforcement, EMS, someone has contact, takes them there, they go to the local emergency department, the emergency department checks them out medically, and then they call us and say, hey, we've got somebody that needs a evaluation, risk screening. We have staff that go out and meet with them in the ED, and then have to make a recommendation to essentially the treating physician and say, we are recommending them go to inpatient services, or we came up with a plan for their safety and they're going to be offered these services. And so, we think that they're okay to discharge. And then the hospital can discharge them with that plan in place, or they can hold them there if we are recommending. That's the civil commitment process. So we say that they need inpatient services, but they won't agree to go. Then we petition the court, and the hospital holds them until the court makes the determination. So that could take a few days.
Oh, I didn't
So
know
people
that.
are held in the hospital as a safe place for them to be until they can get sent to the psych hospitals.
Got it. Wow. That's a process, huh?
It is. So all the partners work really well together, have good relationships, and it's still, it's not the work that like a hospital emergency department is really designed to do,
Right.
to sort of hold people for mental health. It's not really the work that like the court system is designed to do, to send people into treatment, right? So, but everybody is, they play their part in that. But that's how that process works. So somebody gets to the emergency department, we evaluate them, we make a recommendation it's just a recommendation of, do they need to go to inpatient service treatment or not? And if they do need to go, will they voluntarily agree to and stay in the hospital waiting, or will they not? And then we have them held there. And then they're reevaluated every 24 hours because that can change. So the next day we come out, we meet with them again. They're doing a little bit better. We probably are dropping the hold and they're free to leave. Wow. Or we're recommending, nope, same recommendation, and still pursuing hospitalization.
It's very individualistic, it sounds.
It is. Yeah, it's supposed to be an evaluation of that person at that point in time. The other thing that's frustrating to maybe people on the outside looking in is a lot of it depends on what the person says or how they present right there in the moment. And we're looking at, are they saying that they will hurt themselves, or are they saying they will hurt someone else? Or are they so, the term is grossly disorganized, meaning sort of not in the right mind to be sort of safely going about their day, and are likely to get immediately get hurt. So it's usually someone who says, I don't think I can, I want to kill myself. I don't think I cannot, or I'm not willing to say I won't. Or then sometimes it's people who say, are so delusional and they're not aware of what's going on around them, and they need to sort of be kept for their own safety. But the criteria is immediate danger. So, which has sort of been interpreted sort of by the courts and by us to mean within the next 24 hours, something is going to happen. And so we're preventing that by holding them.
By holding them. Wow.
Yeah. But when we have people that are the sort of well-known, have been screened many times, they know the process too. They know when they go to the hospital, they're going to have a screener come. They know the questions they're going to ask, and they know based on how they answer what the outcome of that is going to be. And those are the ones that get trickier, because we have people that will say what they know they need to say, and it's really hard to prove otherwise in a court.
Right.
So, because then that's
wow.
just how it is.
That was a great answer. Thank you. How many people does your department see either or serve them either monthly or annually? Do you know that number?
I don't. I know how many we have enrolled in our services.
Okay.
It's about 2,000.
Wow.
Some of them are different. Some of them, like I said, are lighter touch points. They might come once a month for a counseling session. Some of them are more intense. They're probably being seen every day by somebody who works with them, because they're in some of our most intensive services. But yeah, it's about 600-ish on the youth side.
Wow.
And another, that's actually probably more than 2,000, because then it's about another 1,800 on the adult side. So it's a lot. It's more than people realize, I think. Yeah. And I want to make sure we get to the sort of community crisis, because that was, I think, the sort of new shiny thing, and also the one that is sort of still being developed and sort of, we're kind of doing a little bit of gradual messaging about it too. So we have for years had a small but dedicated mobile crisis team. They're part of our adult crisis, bigger team that's in the clinic and doing the hospital screenings and things, but they were dedicated to working with law enforcement. So we had 3 people, one at a time, working a shift during the sort of swing shift hours of noon till midnight. And what we were doing was co-responding with law enforcement on calls that were mental health related. So often that was the law enforcement, 911 gets a call, they go out, they are on scene and oh yeah, we should really have, we call them COS, it's our community outreach specialists. We should have COS come out and talk with this person. So they call us, we go out, we are there with law enforcement. In that way, we're able to do sort of an evaluation in the community or in the field of, does this person potentially need to go to the hospital? And then if they do, we can have the officers or EMS transport them and then start that whole hospital process and court process. Or can we work with them and calm things down or come up with a plan in the community and sort of just de-escalate it in the moment? So we've had that for years. And what the state is doing now is saying, we want more of that. And we're going to give, so Oregon Health Authority has given money to all the counties to have what they're wanting is a 24/7, 365 mobile crisis team in every county. So we are hiring up to be able to staff it 24/7. And we are, and having it be up to a 2-person team from mental health, so that we don't always go with law enforcement, but we could also go independent of law enforcement and still go as a 2-person team from our services. So we're working on that now. So we're going from a team of 3 that we've had for a number of years to a team of 12, where we'll have basically teams of 2 on 12-hour shifts, 12, 24, and we'll have a full 24/7 coverage then. So we're excited about that. Law enforcement is excited about that. And what we're working on now with like YCOM dispatch, the sheriff's office, PDs, EMS, fire is how do they decide when they go out and then call us? How do they decide when they just tell us this is probably when you can go on your own, and we don't think we need like a uniformed officer to go? So trying to come up with a little bit of that at the dispatch level. How do they deploy their resources? I think this is probably a good time to show the infographic. This is what Oregon Health Authority said, like, here's what we want. And they, this is how the system they're imagining and then sort of funding us to try to build. And ours will be close to this, I think. If I share screen, let's see, there it is. It might take a second to pop up, and then you'll have to let me know if you can read it, if it's legible. It says I'm sharing screen. Can you see that? I don't know if I can make it bigger by zooming in a little bit. Maybe I can find a way to zoom it in.
I can read it pretty well.
Is it okay? Okay.
Yeah.
So what I didn't talk about 988 yet, so that would probably be a good way to get before this. So I don't know how publicly aware the new 988 crisis hotline is, but this is another thing. This is actually a federal plan coming down to the state level to have a nationwide crisis hotline that's sort of similar model and easy to remember number like 911. So 988. So federal funds and state funds have been used to create in Oregon the 988 crisis hotline. It's contracted to a call center that's Lines for Life is the business. They're the call center for Oregon. So if somebody were to call 988 today, the system is already in place. 988 is a mental health and a little bit of like addictions crisis call center. So it's really designed for people who are experiencing a crisis and want to talk to someone, and it's 24/7. And they handle, well, the last I heard, the sort of stats they were reporting was that they resolved like 98% of the calls themselves. But they have the ability to call and deploy the local mobile crisis people to go out in person. So what this infographic is showing is the sort of 2 pathways to get the mobile crisis response. But this is what I'm using it for, at least. 911 is your local emergency dispatch. So you call 911, the 911 operator finds out what the situation is, and then they're deciding, do I deploy law enforcement? Is this an emergency medical? Is this law enforcement going with the mobile crisis team? We're represented by the green on here. Is this emergency medical with the crisis team? And then they sort of dispatch the unit, and then from there the outcomes are, the police can transport the person to the jail or the hospital, or we do not have the crisis receiving center in green there at the bottom center. I can talk a little bit more about that in a second, but so there's sort of the outcomes there. And then the 988 call center is sort of modeled similarly, but call comes into them, they find out what's going on, and then if they feel they need to, they can call 911 and deploy law enforcement, and they can call our mobile crisis people and deploy them. And so they do that now, but not very often. Like I said, they said 2% of the time. And then our team would go out and respond, or law enforcement would respond, and we'd meet with the person in the community. So what we don't have right now is this is the number you call at HHS to have mobile crisis come out. There's this sort of call center and dispatch, so that these are easy to remember numbers, 24/7 operators, and then they're making that decision about what's needed in the moment, and then sort of sending out the resources. So for community members, good to be aware of the 988 and the ability, but it's and I'm sure they would take like and I don't know if there's a better way to say it, the sort of concerned citizen call, like, hey, I see someone who I think is experiencing a mental health crisis. I think they take those, but what their core function is talking to the person themselves and trying to help them through it, if that's possible. Crisis receiving center. So some larger counties have a 24/7 staffed and open crisis receiving center where law enforcement or the mobile crisis team would take someone, and it's like either like a shelter model. So like, hey, you can go and stay here, and there's staffing and services on site, and it helps you sort of through this immediate crisis you're in. Yeah.
So the city is going to be putting in a navigation center. It's going to take a while to put it all together. So is that a place where people in crisis could go, or is that not going to be the right place?
I don't think that they would always be able to do that. So I think it's possible that I think that we could be a pathway into the navigation center. It might depend on like, do they have, like, they're going to have the number of beds and their capacity or wait list. And so it might depend on if they have bed availability. And then it also might depend on hours of the day. Like if they're saying like, hey, we would admit someone during business hours. If we have a bed, you can call us. But some of these 24/7 crisis receiving centers, where it's, and I don't know how they manage it for like capacity. They must have limits too at all of them. But basically the idea is, you come and you drop the person off, and then we will take care of them for a period of time and try to stabilize them. We have our own little scaled down version of that, that we refer to as the peer assisted crisis house. It's just a house. It's not a center or a facility. But we have the ability to have like 3 to 4 people staying there at any given time, and then it's staffed 24/7 by our staff. So we have people there usually that are at risk of suicide, but not going to the hospital level, and they're willing to go there instead. So we can keep a little better eyes on them than just releasing them from the local emergency department. So for us, it's mostly people that would have gone into the emergency department or are being released from the emergency department. And this is like a safe place to stay for a little while. And most people stay there like a week. So we do have something like that, but it's just not like 24/7 access to the community. It's a small number it can actually house. But so this is kind of the crisis system that Oregon Health Authority is wanting and trying to fund and giving us sort of a year of implementation time to get off the ground. We're in a good place locally because we already had a sort of a model. We just didn't have it staffed up. Now we have more money from the state, so we're staffing it up. So we're able to do that pretty quickly. We already had the relationships with law enforcement. And we already were working actually with the crisis call center too, because we were working with a contract with Lines for Life before they were 988. So we paid them to be our local crisis number. And so they already could call our COS team before this. So in a lot of ways, we were set up well for this system to be running now, which is why we are very close to having 24/7 coverage already. I think we're like hiring so that we have enough for the 2 people teams. But so what does COS do is the next thing, like who do they serve? What do they do? Largely, historically, it's been law enforcement calls. So usually it's somebody who is experiencing a mental health crisis, like they're suicidal and they can't sort of keep themselves safe. Sometimes we get called out for like the probably escalated arguments and things like that, sort of domestic situations where we're going to be able to help. The officers are good at that too, like de-escalating. They're trained to do some of that. We're going to come and try to help too. And sometimes it's about, hey, we can offer you some other services if you want to come and see us, and like trying to connect them into the services that are available. And then some of the calls are the sort of, I'll say, people that appear to be experiencing a mental health crisis, like erratic behavior, talking to themselves, kind of behaving in odd ways out in the community. And some of those are unsafe. So, law enforcement gets called, especially if it's unsafe and people are, wandering in traffic is a good example. Wandering in traffic, the police should be called because there's this community safety issue. And then we're probably going to get called or come out because there's probably a mental health thing going on, or sometimes a substance use related thing going on that's causing some of that behavior. And so those are the appropriate calls that we would go on. We're going to try to do a little bit more, even if someone doesn't look like they're in a crisis mode, they are, this is a little bit of yet to be sort of really fleshed out, but it's not supposed to be strictly like homelessness outreach, but it would be ability to talk to someone who is homeless and offer services that we have available for counseling and things like that. So often we don't have a way to get people off the street, but we might be able to go out and say, hey, are you willing to, would you come in tomorrow during business hours? Hey, we can get you signed up for some things. Oh, you used to take medications, but you don't anymore. Would you be willing to start again? Like all of that. So like some of it is, I think, being willing to go out and do that outreach and engagement, but the outcome of that is not usually include housing for people. It just sort of includes connection to some of our services. Hopefully they're safe in the community and we can help them make choices that are safer, or and when people are like I said, grossly disorganized, causing themselves danger, then that's where like we might have law enforcement transport them to the hospital. So those are the kinds of calls we go on often. We probably get a few a day, like countywide. And we are actually, with the increased staffing, we're wanting to take more calls. Like we want to make sure that we're meeting more of the need. For a long time, it was only the most extreme crisis was the ones we were getting called out on because we only had capacity for that. And now we are building it out to be able to respond more to the sort of routine level, and also then like follow up with people. So, hey, the crisis team was called out to meet with this person. And then like 2 days later, we might say like, hey, can we check in with you? Do you have a phone number we could call? Or would you mind if we swung by here tomorrow to see how you're doing? And so part of the model that we plan is to do the follow-up or outreach within like 2 or 3 days after the first contact. Or make sure that they already have they're already in our services and they already have an appointment and things like that. So make sure there's follow-up and it's not just a one-time deal when we go out. So that's a lot. You probably have questions. Yeah.
Someone has, do you think that there's a question in the
sharing.
chat box? Do you think that a primary need in the community is a place for people to be?
Yes. Well, so I said that emphatically. There are so many needs. Gosh. There are a lot of people like separating out the economics. There's a lot of people just with mental health or addictions that have barriers to housing, right? They've lost housing, they can't afford housing, they're kicked out of their housing, whatever. They need a place to be. And then we have shelters and things like that, like missions, shelters, programs, but usually often those programs have either limited capacity or eligibility criteria or rules around being intoxicated under the influence or sort of aggressive or threatening, things like that. So a lot of the time there are people who, even if they would go to a shelter, aren't eligible to. So one of the things is like low barrier shelters, meaning they don't have a lot of requirements that rule people out. And then you're serving a kind of different population than maybe your sort of general homeless shelter that might have families with children and things like that. So you have different populations you need to serve sometimes. And how do you separate that and make that feel safe for everybody? But yeah, low barrier housing or sheltering is a need. There is a need for, like, if we're just talking like statewide, there's a need for more psych hospitalization where people could stay longer and get care. There's a need for something between the most extreme psych hospitalization and then just voluntary appointments in a clinic. And there's some specialty programs and things like that, but most of them still depend on people living in the community on their own. And then like either we go out to them or they come into us. So very few of those programs provide the housing or sheltering. The ways that does happen in a positive way are few and far between, but it's like adult foster care. So somebody could, this is like the sort of that gap between people who are civilly committed and people who just are voluntary. A family member or a concerned person could petition a court for guardianship over someone who is not able to safely make those decisions for themselves. And so sometimes we've got adults, legal adults, who have a guardian, family member usually, and the guardian makes healthcare decisions on their behalf. And sometimes those people are voluntarily living in an adult foster setting, which is like a child foster setting where you've got a home and a certified licensed home and a person who lives there but sort of operates the home and is the sort of supervision. And they do, maybe a little bit of care providing, like cooking meals and things like that. So we do have, I wish we had a lot more adult foster homes. We have like 3, I think, in the county. So it's hard to get into those too, just like hospitals. So it's really hard to get into like the treatment programs and the foster homes and things like that. So most people are on their own for housing. And if they can't successfully do that, then there's not a lot of other options. The other thing that this is maybe, I don't know, it's beyond my scope is like healthcare, but at the risk of that, we have a lot of people that are living out of cars and campers and things like that. And having places that they were allowed to be would be helpful. Because there's a lot of places they're not allowed to be. And it's better than being on the street, I think. But so whether, I don't know what that looks like. And that's sort of outside of my scope, but there's places that people could be is a need. And then things like the navigation center that, and YCAP does good work around this, but trying to get people rehoused, which is a process and takes time. And so what do they do in the interim? But there are services to get people rehoused. There's funding to sort of remove barriers like your rent application fee and your security deposits. And like, there's funds for that kind of stuff. If people can get eligible for Section 8 vouchers and things like that, that could take a year or two sometimes. Like, so there's some shortcuts and there's some things that just take a long time, but people need a place to be sometimes while they're waiting to go to something that's more permanent. Yeah.
Thank you for that. I have another question. So there's organizations like Provoking Hope and places like that. So do they refer people to you? Can you refer people to them? How does that work? Is that relationship?
Yeah, we are probably the largest funder of Provoking Hope. So we contract directly with them. So they work with a lot of our clients in their role of certified recovery mentors. So they're focused on addictions only. And they are peers, people who have lived through their own challenges and come out of it and now are wanting to help others. So we contract with them. They do work with some of our open clients that are in our CD program, our addictions treatment programs and things like that. They also then do some sort of just like general community outreach where they've got like their walk-in hours or their community center, and they do some groups and classes and like parenting classes and things like that. So we do work with them, and they do a little bit of outreach, especially around things like overdose. That's the one we've tried to say, like, hey, like overdose is like clear, like good opportunity for you guys to get involved. And they're doing things like Narcan distribution for intervening for an overdose, and the clean needle exchange program, things like that. So that they've got their sort of their body of work around reducing harm for substance use disorder, and then sort of the motivation and encouragement to get people in to see us for treatment. So that's the goal, is that they are sort of out in the community and the first contact with a lot of people, and then working with them over time when people are ready to come see us.
Right. You mentioned Narcan, and I had heard that there was a Narcan shortage. Is that, have you heard that?
It may be hard to come by because everybody wants it now, which is a good thing.
Right.
We still, so public health, which is part of HHS, is able to sort of order it. And I don't know if they're always getting their orders filled, but they're able to order it and distribute it locally. So we've been distributing it to like law enforcement, Provoking Hope, like our clinics and offices all have some doses like in the building, EMS. But there's a sort of campaign to increase the sort of access and distribution of it so that like anyone who sort of wants to have it has it, because there's very little risk or downside to using it if you didn't need to, but it could be life-saving.
Right.
Yeah.
Yes. Well, within the last few months, we've had some deaths from fentanyl because could not get what they needed, or it was just, the drugs they were taking were laced, and it was, that's just tragic.
Yeah.
I had another I know, where are the locations of services in McMinnville so say we're on the street and we see someone, right? And it's happened here. I actually have your HHS crisis response team number sitting on my computer, because we've had to call a couple of times, and people have been incredibly responsive and super helpful. So we're a business owner, and we are we have someone who's either walked into our business that is clearly in a crisis. Are we to call that number? What we should do is call that number or call police. That's always the dilemma.
If it's during business hours, like Monday through Friday, 8 to 5, the number you have might be our office number, I'm thinking. I don't know. It depends on who you got it from, I guess. It's probably not the mobile crisis direct number, which we don't really distribute. But it might be our office number. I'm not sure.
It could be, I don't know.
But if it's during business hours, so if it's Monday through Friday, 8 to 5, and you call adult behavioral health services, which is like, I can look it up. I was gonna say, don't
worry about it. It's all good. Don't worry about it.
If you call that and say, well, two things. If you call that, the first thing you get is like a call tree recording that says, if you have a crisis, press 2. That kicks you to the crisis hotline, Lines for Life. So you're no longer local. You're talking to an operator probably in Portland. But if you stay on the line or get the operator, then you're talking to our front desk. And then you say like, hey, can I talk to the crisis team? They're going to put you through to our staff that are just hanging out in the office. Those are the people you would want to talk to, because that's where you could say, hey, could someone come down to the corner of such and such and such and such, and meet me with this person here. And they'll either come out themselves, or they'll be like, yeah, I'll send out the crisis team person who's, around maybe in the community. So that would be the way to do it during business hours. During non-business hours, your best bet's probably calling either 911 or non-emergency dispatch.
Got it.
But non-emergency dispatch is probably good if it doesn't feel like it's an emergency. And then just saying, hey, we're really concerned about this person. Is there any way we could have an officer come out and maybe get the crisis team? And they might send the officer and the crisis team. They might just send the crisis team, depending on what you describe is going on. But that would be the best way to do it during those sort of non-business hours. And you can do it during business hours too. Like you could always just call dispatch. The only thing I was thinking about is during business hours, proximity, we might get there faster just from our office walking over than calling dispatch and then them calling the crisis person who could be out in Newburgh and then driving back, right? So, that's a good call out. The mobile crisis response time is supposed to be within an hour because it serves the whole county, and it's potentially one person having to travel from anywhere in the county to somewhere else in the
Right.
county.
Yeah, it's a big camp. So if
Yeah.
someone was in Mac and they needed some local services, where would they go? I mean, they could call, right? But
Mhm.
where are you located? Is
Yeah,
it the office on
so
Fifth Street? Is that where people
adult
go?
behavioral health is probably where they would want to go, assuming they're adults. And um, 6th Street between Davis and Evans, and you can enter the building from either Davis or Evans.
Oh, okay.
So just north of the parking structure
Right.
is the other way to say that. So on the north of the parking structure is adult behavioral health, and it has, you know, doors on either side. You walk into the lobby space, there's a front desk counter, and the receptionist, you know, can I help you? They could say, yeah, I want to get signed up for services, or I really need to talk to someone right now.
Great.
Awesome.
Awesome.
And then that's kind of where we go from there.
That's awesome. And if a business has an employee that's struggling, they could send them to you as well, correct?
Yeah, if it was like a, hey, we're really concerned about our employee, maybe it's not a crisis, but like they could use some counseling or some help, right? And maybe it is a crisis. You could refer anyone to us that sort of lives in Yamhill County. They could call in. So we try to say like, no wrong door is our access sort of model or philosophy, which means, and sometimes people are like, how do people get connected to you? And I say like a lot of ways, and that can be confusing too, but people can self-refer, they can call or just walk in. Primary care refers to us, you know, family members call us and say, I'm worried about and we'll say like, do you mind if we call them, or can you bring them in? So we get family referrals, we get self-referrals, walk-ins, doctor's offices, schools, mandated like parole probation officers sending their people.
Yeah.
So what someone would expect if they just walk in would be there's, of course, unfortunately, paperwork you fill out. So they would fill out paperwork, and a staff person would like sit with them and help them like explain what it is and things like that. But there's paperwork to fill out, and then they would schedule you for an appointment. You would come back for that appointment. There are some times when that is actually like, you're going to stay and we're going to see you right now, where like there's a crisis and we're like going to have you come talk to the crisis counseling team. And then the other thing that we do that's like same day access, which could apply in some of these things you're talking about, and it's the first time I've mentioned it, is medication assisted treatment. So this is like medications that are supposed to help with addictions, like withdrawal and cravings. So it's like your medications for like people that are using opioids and things like that, or alcohol. So there are medications that are supposed to help someone who is going to likely use again, because as soon as withdrawal hits, they're going to want to use again. So those are like same day access. So someone could walk in and be like, I'm trying to get off and I need help. And we could say, hey, you know, if you got the time, we'll do the paperwork. You'll go into an assessment with someone that could take like an hour or two, and then we're going to have you see a nurse, and then you're going to see the prescriber, and you're going to walk out of here with medication that's going to immediately start helping with that.
Wow.
So that's MAT, medication assisted treatment, primarily around opioids, and you know. I'm trying to think of what else it would come up for. Probably the number 2 is alcohol withdrawals.
Yeah.
Also very medically dangerous without. So
yeah. Wow, it is 2 after 2 and my goodness, our time flew by. That was really fascinating. Thank you so much, Jason. I don't know if there's any other questions.
I was just thinking,
yeah.
So my contact information, I can either throw it in the chat real fast, or I don't know if Rhonda wants to send it out to everybody. Like I don't like the distribution list or whatever, but like Rhonda has it. So
yeah, Rhonda has your contact information.
Okay.
And you know what she could do? She could just put it when we post this,
Mhm.
she could put that up there for more information.
Yeah.
The contact.
And I would just say, I'm glad to hear that like there's been positive experiences. Part of my contact information is like, hey, if something doesn't work the way I said it should, I want to know about it, right? Because it's like,
Yeah, absolutely.
I'm up here talking about the way the system's designed, and sometimes that's not the experience for someone. So I want to hear if something doesn't go well,
Sure.
so that we can try to solve for that.
Yeah, you bet.